This is Dr. Wurzberger. Before we look at some video of arthroscopic surgery, I wanted to give you a perspective of what we would be looking at. In arthroscopy, we see the leaf and not the tree and not the forest. If you look at this picture of a knee joint with the kneecap removed, you can see the end of the femur, the upper end of the tibia, the cartilages in between the bones, and two ligaments crossing in the middle. That's fairly recognizable even if you're not experienced in medicine. This is something that gives a perspective as to what you're looking at. If we were to look at this skeleton with the knee bent over the table and two black dots where the anterior cruciate ligament attaches on the femur and in the tibia, that too gives a good perspective of what we're looking at. Even if you're not experienced in medicine or knee problems, you have a feel for that. Out of the blue, if we showed you this picture, you'd probably have trouble recognizing what you're looking at. These are the two black dots where the anterior cruciate attached, but we've come up so close on it that you don't have a perspective. And that's what I mean, you're looking at the leaf and not the forest. Keep that in mind while watching the video. I'm going to show you what we do when we repair a meniscus. A small number of tears are such that the cartilage itself is okay, but its attachment to the outside ligaments of the knee has been disrupted. This allows the cartilage to displace into the knee, but the cartilage itself is really not badly injured. We can repair these by stitching them up. The percentage of cartilages that are amenable to repair is small, and the rehab is harder. What we do is stick this suture in through the side of the knee, through the meniscus, tie a knot on the end like that, and then pull it back through to butt it up against the meniscus and push it up against the tissue we want it to heal to. We do this arthroscopically. And now we'll show you a procedure where this was done arthroscopically, with the perspective that everything is magnified, but this is what we'll be doing. This is an medial meniscus problem, which is more complicated than the usual. This is on a young patient that I did an anterior cruciate reconstruction, but he also had this medial meniscus tear. Now you always try to save a meniscus if you can, because you're going to get arthritis if it's removed. Some you can't help removing. This particular tear was more complex than usual because it was torn back at its attachment and also in the middle of the meniscus right here. Now you can see there's this tear right there where I'm biting, and that tear was in what we call a white zone. So I thought I had to take that back to that spot at all, but I wanted to try to save the rest of it if I could. The problem is back here where the probe is. There, you see how loose it is? It displaces into the middle of the joint and locks the knee, because it's torn away from the ligaments that it normally attaches to. So with this instrument, which is a rotatory instrument, it irritates the back of the meniscus where it originally was attached properly, and this will cause this to bleed. It doesn't bleed now because the tourniquet is up, but when the tourniquet's let down it would bleed. And so we get that prepared back there, and then that meniscus can heal back if stitched back and treated properly. So we have the bulk of the meniscus available for repair. Now I'm going to go ahead and do this outside in repair that I showed earlier in this video on the model, and you can see how we stick in our spinal needle, thread in a thread, tie a knot on the end of it, and pull it back in. And we'll show you that in just 1 second. Here's a second thread we put in. And these knots can go under There's one. There's two. And I can tuck them back under, and this pushes the meniscus back so it won't come out of position while it's healing. Here we're putting a stitch back here in the back now. There's a complicated tear up here in the front too that we have to do a little more trimming on, but for the most part we're saving the bulk of this meniscus. Here's another stitch. We usually put about 6 or 8 stitches in. There we have pulled that back like yay. And these stitches are dissolvable, so in a month or so, for the most part, will have lost their strength and will be dissolving. So there won't be anything in the joint to irritate the joint or be permanent in the joint. It'll be gone. And that's the beauty of this, I think. There are a lot of newer ways to repair this, but none of them really are quite as good as this. And this is harder to do, but very reliable. There's our knot there. There's another knot there. So basically it's good meniscus repair. We've got the ACL reconstructed, and this patient did well. Had no problems after he finished his rehab.